Hello and welcome to my primer on prostate cancer. What I'm drawing together here in this primer is everything I've learned in the last 2.5 years about my disease and about prostate cancer in general. And I'd like to pass this information on to you, bearing in mind that when I was first told that I was seriously ill with prostate cancer, I really had no clue what that meant. And I've called this "The Tide is Turning" because prostate cancer has come of age. It's now in a very mature position, and no man need to be worried about coming forward and being checked for prostate cancer. So let me make a start here and take you through it. My introduction is, of course, the PSA, which is where you start. But before I do that, I'd just like to comment to you that I'm a person who's pretty frightened of medical things. I've been that way all my life. It took me a long time to actually pluck up the courage to ask for a PSA test, because even having a blood test I used to be worried about. But I did, and I'm glad that I did. And I think you'll probably see why as I go through this. But for those of you like me who are very nervous about medical things, do not worry. There's only limited medical content here, and I will be showing you no images that you will be upset about. The other thing of concern, particularly when you're a male and something's wrong down there, it's a bit embarrassing. I was in that group of people as well, but eventually I decided that I didn't really want to die embarrassed. I wanted to find out whether I could have life. And so I put the embarrassment aside and I made that first PSA test. So what's PSA? PSA stands for prostate-specific antigen, and it's a molecule that's produced inside your prostate gland. And some of it gets into the bloodstream, and it circulates in the bloodstream, and you can measure it. And when it's measured, it's always measured as nanograms per milliliter of blood, or ng per ml. And so it's normally just quoted as a number because everybody knows it's ng per ml. So what numbers do you expect? Well, in the UK here, and different countries have a slightly different breakpoints. In the UK, if you're in your 50s and you have a PSA value that's above 3, you should be thinking about finding out whether you've got prostate cancer. In the 60s, that number goes up to 4, and after you become 75. Now, it's a bit blurred after you're 70, and I'll comment on that in a moment with what I'm about to show you. I'm going to show you 2 PSA values here. My PSA value, which was taken in January 2018, was 7.6. Now, my GP said to me when he was reading this out and I was sitting in the surgery, he said, look, over 70, I wouldn't worry unless it was 10. And I looked at him and I thought, 5 is a number that kicks around, I looked at him and I said, well, it's a lot bigger than 5, is what I'm concerned about. And there was a bit of a debate, and he allowed me to go forward and be tested. And thank goodness, because I was getting pretty close to being in an uncontrolled situation with the disease. On the other hand, a cousin of mine in Australia, who's the same age as me, incidentally, he was diagnosed at 57, myself at 73. He was diagnosed in 2002, and his PSA was 100. And he was of identical illness to me, stage 3. So the number itself is not particularly relevant. There's a wide range of PSA values. How wide is it? Well, the largest PSA value I've heard of is in the city I live in, Edinburgh, and it's 10,000. And that man is still alive, and he's doing fine. I haven't met him, but some of my friends have. So whatever number you get, do not get concerned until you have had further tests and you know the extent of the actual disease you've got. Because, and let me say it again, the PSA value is not sensitive to the amount of cancer you may have in your body. And in the UK, you have a right to have a PSA test if you're 50. Don't be fobbed off. And certainly don't be fobbed off if the GP says to you, but look, you've got no symptoms. I had no symptoms. The GP tried to fob me off, but I pressured him and I got my PSA measured. And you have a right to have that. He cannot fob you off. He could try to talk you out of it, but he can't fob you off. And you have the right to have that PSA test if you're 45 or over, if you've got PSA in the family. That's generally quoted as a father, a brother, or an uncle. In my case, I had 2 cousins, both the same age as me. And so I was concerned. That's why I wanted to be measured. Finally, if you do have your PSA measured, and I hope you will, only 20% of men with raised PSA have prostate cancer. There are other illnesses of the prostate gland that are benign, and they'll be looked at if you've got a high PSA. So once you've got your PSA value and it's abnormal, high, you will be referred to a urology department where you will have, these days, if it's an up-to-date urology department, you will have an MRI scan. It's called mpMRI, and the MP stands for multiparametric. It's an MRI machine that's been set up in a special way for prostate cancer that's able to find prostate cancer cells. So after your referral, you'll have your scan, and the mpMRI scan finds prostate cancer if it's present. So this is the moment in time when you find out you've got prostate cancer. And take note here, if you, like me, are frightened of medical things, none of this is invasive. To find out if you've got prostate cancer, all you need is a simple PSA blood test and an MRI scan that is non-invasive. And you'll know. And you'll know if you've had the PSA test and it's low anyway. You may not be able to have an mpMRI scan. You know, the classic example of this is a heart pacemaker. You cannot have an MRI scan if you've got a heart pacemaker or some metallic part to your body of any description, because these are massive magnetic fields in the MRI scanner. 100,000 times the Earth's magnetic field. They're big. But you will be offered a biopsy, which was the classic way of detecting cancer on abnormal PSA until the MRI scan came along. And clearly the MRI scan is better, so that's why it's used today. Now you need to, and go back to the MRI scan now, I won't discuss the biopsy at this point. You now need to know how to interpret all the parameters that come off the MRI scan, and indeed, in particular, the stage of your cancer. This cancer goes through 4 stages, and I'm presenting here an idealized model. There's always the exception that proves the rule, so to speak. But if you understand this model, you'll be able to understand anything you're told as to where you are on this chart. Okay? Prostate cancer goes through 4 stages. You can think of time starting here and going to here. You have no prostate cancer here, and death is at this green line here at the end. That's if you do not get tested or treated. Okay, this is a person that never got tested or treated. Although I've got equal amounts of time here in the stages, that is not true of life, and they will vary from man to man, in fact. So initially, the cancer starts to grow. It won't be very big at first. That's called stage 1. But if it continues to grow, and it doesn't always, by the way, if it continues to grow, it'll pass through this boundary here into stage 2. Eventually it'll pass through to stage 3, and eventually to stage 4, and finally death. Now I've got 2 letters in stage 4 here, A and B. You can think of stage 4 as being a completely different disease. That's the best way to think of this. In other words, what's wrong with you here is different from what's wrong with you throughout here. Let me just deal with B first. If you don't get tested for prostate cancer until you have gone through all these stages and got to this point here, near to death, and you come forward and get tested, you're in a very precarious position. You may only live for months, 6 to 9 months. But if you're afforded chemotherapy, or indeed a very new treatment called Theranostics, you can boost that to over 2 years. So it's moving forward. You can be quite close to death, but brought back from it. Point A here is slightly meaningful in that your prospects of survival for stage 1, stage 2, and stage 3 are approximately 100%. I'll repeat that, approximately 100%. Very few men die with stage 1, stage 2, and stage 3 prostate cancer. And I would think there would have to have been something else wrong with you for that to happen, because these 3 stages can be dealt with. So once you get into stage 4 and you're in this different disease era, that you start to get worried. And the statistics that are published, and I'll show you some at the end, are published out to 10 years. So if you make it past 10 years, and my cousin in Australia is 18 now, if you make it past 10 years, you're not in the stats anymore. So if you die at the 11-year point, that won't be recorded. And the statistics are now showing that you can be well into stage 4 and still get 10 years. And I know people that that's happened to. People with a PSA of 500. Goes up to 700, they have chemotherapy. Goes back to 500. Live for a while. Goes up to 700. Chemotherapy again, down to 500. And you can last beyond 10 years. So at all stages from here up to this point A here, you can look forward to quite a long and in fact, pretty high quality of life existence. Beyond A and up to B there, and B itself, you are beginning to get into that situation where you probably will have less than 10 years of life left. So, just to recap this, if you've got stage 1 prostate cancer, you could expect a full cure. Indeed, stage 1 is not treated, and I'll come on to that fairly soon. If you've got stage 2 prostate cancer, you could expect a full cure. If you've got stage 3 prostate cancer, you can expect a full cure. If you've got stage 4 prostate cancer, there is no known cure. But that doesn't mean to say that you're about to die. It's a chronic disease in stage 4. You get what's called remission. It'll go away, and then it'll come back. And you'll treat it again, it'll go away, and then it'll come back. So you're always having to fight, keep on top of it and treat it as and when it crops up again. And this can be done for years, absolutely for years. So even if you're in stage 4 when you're first diagnosed, you can look for quite a lot of life if you get into good remission situations. So let's have a little bit more fine look at these 4 stages. Stage 1, the cancer is entirely within your prostate gland. That's where it starts. Prostate cancer always starts in the prostate gland. This cancer is no threat to your life. It's called indolent. And the way it's handled is by active surveillance. You'll stay in the system, and about every 6 months you'll get a PSA measurement, and perhaps at 12 months or even longer than that, depending on how little cancer you've got, you'll have an mpMRI scan to check how far it's advanced since your first time. And the cancer may never advance to stage 2. So a man in which this happens, he's just under active surveillance for the rest of his life, basically. When he dies, he won't be dying of prostate cancer, even though it's in his prostate gland. He'll be dying of something else. You may see staging letters and digits in your notes, or you may be told them. T1A, T1B, T1C. T stands for tumour. stage 1A tumour, stage 1B tumour, stage 1C. And in a sense, you can look at this as small amount of tumour, bit more. So it would be such a cancer will be progressing and likely to go to stage 2. Stage 2, same as stage 1 in some respects. The cancer is still entirely within your prostate gland, hasn't got out anywhere, but it's now big enough to be called clinically significant. That is, it's going to be treated. And the classical treatments are radiotherapy, which kills the cancer in situ. EBRT stands for external beam radiation therapy. And so you've got an external beam fired at your body, goes straight through, it's fired at the prostate gland, of course, straight through, killing the cancer in the prostate gland as it does. Does a bit of damage to your other cells, but it kills cancer. Brachytherapy, that also kills cancer in situ. In brachytherapy, small seeds are placed into your prostate gland in a particular arrangement. They have a half-life of about 2 months, and so they're kind of dead by the time you get to 10 to 12 months. But as they're dying, they're killing the cancer with radiation. They're left in the prostate gland. And the third way, is surgery, and that is the complete removal of the prostate. Now, there's a slight attraction in surgery because you're taking the prostate gland out of the body and throwing it in the bin, and so you're removing the cancer from your body. And it's been the workhorse probably 50 years now. But surgery has one or two side effects that make it these days, and this has all been studied and researched and published in papers, make it the third choice these days behind radiotherapy and brachytherapy. And the reason I put radiotherapy at the top of the list there is because in order to have brachytherapy, you have to have an appropriate arrangement of the cancer inside the prostate gland. If you've got a big clump on one side, for example, you won't be offered brachytherapy. It's got to be distributed in a reasonable way. Brachytherapy, when it can be applied, my belief is that it's slightly preferred to EBRT, and even better, some research papers show that if you have both EBRT and brachytherapy, you have a better prospect. But I don't think it's a lot. I mean, if you last 10 years after EBRT, you might last 11 or 12 if you have the combined one. That sort of thing, before you get a recurrence, not before you die. So think carefully if you get into this position. You may be frightened of radiotherapy, but I will talk about this in another video and give you some idea that it's not something to fear. And in fact, I had radiotherapy myself, and I have very, very small side effects. I'm just living a normal life completely. In stage 2, T2A, the cancer is smaller than 1/2 of the side of your prostate, but still clinically significant. T2B, it's more than 1/2 of one side of your prostate, and T2C, it's in both sides. Stage 3, the cancer has now burst out of the prostate gland. It's got out. You've left it, this is me. I left it too long, and it grew so big inside my prostate gland that it broke out of the prostate gland through the capsule, as it's called. It's now serious. Treatment is required now. And the reality is, the only real choice you have at this point is EBRT. Brachytherapy is no use. Brachytherapy only works inside the prostate gland itself in a particular arrangement. It doesn't work outside of it. Not very well. You'd have to put seeds all over the place. And they don't do that. You may be offered surgery. I'd be very wary of having surgery at stage 3, even if you did want it at stage 2. I'd be wary there as well. But stage 3, the surgeon, when he takes your prostate gland out, takes only the prostate gland out. He cannot see the stage 3 cancer. It looks the same as ordinary tissue, so he can't scrape it out. So he takes your prostate gland out, puts you back together again, and you've still got cancer in there because it got out of your prostate gland. So you'll probably have to have radiotherapy now to deal with that. So you might as well have had radiotherapy in the first place. So if you're stage 3, think very carefully before having surgery, if you feel you want surgery. EBRT is given in conjunction with what's called hormone therapy. Now, hormone therapy, the technical name for it is ADT, androgen deprivation therapy, and it's a drug or chemical that's either ingested as a tablet or given as an injection. And the theory behind hormone therapy is that it removes testosterone from your body. So you are, as a man, emasculated. Why does testosterone have to come out of the body? Testosterone is the fuel for prostate cancer. If you remove testosterone from the body, the prostate cancer stops growing. So but you can't use it forever, because eventually that tumor will win. But you can use it for quite some time. And some treatments for an older man, for example, some treatments are just hormone therapy. Basically, keep the cancer down, stop it from growing. And indeed, when I had a long think about this and I asked an expert, I was, with my stage 3 serious prostate cancer, I was living fine. I didn't have any symptoms at all. And so I did ask the obvious question: if I have hormone therapy for the rest of my life and there's no testosterone in my system, does it just stop growing there and I just carry on? And as I say, the answer is don't do it. The cancer eventually wins. So it's an adjuvant. But it's given before you have your EBRT, typically 3 to 8 months is the figures that they quote. In my case, it was 3.5, because the hormone therapy shrinks the cancer as well as inhibiting its growth. And if you shrink the cancer, you need smaller beams to kill it, and therefore you'll be having less damage to your body. And that works very well in today's world, because it's a very accurate technique for killing cancer. You'll either have T3A or T3B nomenclature for your cancer. The cancer hasn't gone very far if it's A. And in B, the key thing is that it's invaded the seminal vesicles, which are attached to the prostate gland. Now, interestingly enough, the prostate gland and the seminal vesicles are part of your sex organs. And indeed, the prostate gland is the gland that produces the ejaculate for sexual activity. So it takes out, you have a dry ejaculation. There's no fluid to ejaculate with. So I would argue that if you're thinking of surgery, think twice, because the reservoir for your sexual activity is being removed from your body. And particularly if you've got stage 3 and the seminal vesicles go as well. That's called a radical prostatectomy. It's called a prostatectomy when you take the gland out itself. So you should check on these things if they're of a concern to you. Finally, to stage 4, this is the dangerous stage. The cancer has now not just been locally advanced, as stage 3 is called, it's now got about your whole body, typically taken by the bloodstream and the lymphatics. And it likes to settle in the bones and the lymph nodes. Where it settles, they're called metastases. The singular is metastasis. And they're often referred to as secondaries because the primary tumor is in your prostate gland, and these are secondary little tumors that are building up in your body all over it. You've got a cancer field now in your body. This is why it's getting what's called high risk. Treatment is now required. Now, for this stage, treatments are specific to case. I don't want to drill down too far here, because where it is in your lymph nodes or your bones, the experts will find specific ways of handling it, depending on where it is in your body. So it's a big topic, this. But one of the things that is very easy for me to say is that this is where you get chemotherapy. You don't have chemotherapy in stages 1, 2, or 3. It's only in stage 4, because chemotherapy is specifically for handling metastases, not your actual cancer, your primary cancer. And chemotherapy is applied in rounds of chemotherapy because it's also damaging to your other cells. It's called systemic. It goes throughout your whole body. And it kills lots of things, but it kills cancer faster. That's the theory. So you do get some other damage to your body, which is why you stop having chemotherapy for a while, and your body recovers, and then you have chemotherapy again, and so on. That's why this is the chronic stage of your disease. I'll talk about theranostics a little bit later. The nomenclature for stage 4 is a little bit different from 1, 2, and 3. Here's a typical stage 4 nomenclature: T4, tumour 4, N0, M1, B. So this would be stage 4 with no lymph nodes invaded and centres of the disease in the bones. So they're using the letter N for the nodes and M for the bones here. I want to now talk about 1 or 2 treatments that I haven't had, for example, or are not in the classical list that I gave you earlier, but are quite valuable as ammunition for someone coming in with cancer. Prostate cancer. Focal ablation. The word ablation applied to prostate cancer means getting rid of a tumour in your prostate gland other than by EBRT, brachytherapy, or surgery. So it's got to be some other way of doing it. And focal ablation means going right to where that tumour is and just knocking that tumour out, leaving the rest of your prostate gland undamaged. So this is a very seriously interesting way of handling prostate cancer. It's been around for more than 10 years, in fact, in some parts of the world, particularly in the Netherlands. They went ahead in this. And generally speaking, at the moment, you will really only get it in private clinics and not in your main hospitals. It's a minimally invasive technique because a needle is inserted into your prostate gland, and on the end of that needle, there'll be a transducer of some sort, which may be a laser or an ultrasound transducer or a cryostat, where liquid argon is pumped out and freezes the cells to death. The other ones heat them to death. And there's also an electrical way of doing it called electroporation, where 2 needles are placed in your body and an electric field is put on them and it kills the cells between them. So these are coming on stream, and where they're going to have a big impact, and that's having that impact already, is if you get a recurrence. So in the future, I may get a recurrence, and it's got to start somewhere. And we'll know that there's a recurrence because my PSA value at the moment is running at 0 since I had my EBRT. If it starts to rise, that means prostate cancer is growing again in my body. Now, it might be metastases or it might be in my prostate gland. So the first thing to do is have an MRI scan. And if you catch it quickly, it'll be very small. I know of one instance where it was 4 millimeters long, and that person had focal ablation. So, and it's important in another way, and that is that after you've had radiotherapy, you cannot really have a second round of radiotherapy. It's quite damaging to your organs if you have it twice. And that's why in the past, many people elected for surgery first, because if there was a recurrence, they could use radiotherapy. You can't do it the other way around. If you've had radiotherapy, even surgery is risky because of the damage that's been done. So with the advent of the ablation techniques, and there's several of them, you can quite comfortably choose radiotherapy as your primary way of dealing with the cancer and still have a backup if you get a recurrence, and that backup is the ablation. And so it's going to have a strong place for recurrence. It may also be very good value for stage 2 cancers, where it might be a 2A, for example, a small piece in one side of your prostate gland that needs to be clinically dealt with. So you could actually opt for focal ablation instead of radiotherapy, brachytherapy, or surgery. So you've got a choice there if you can find someone with focal ablation and they've done quite a lot of it and they're very good at it. But for those people who've got stage 1 tumour, part of this grouping is very nervous about living with cancer in their body, not doing anything about it, because it is a bit unnerving, actually. I remember back to when I was first diagnosed that right up until I had my treatment, my whole focus was get this out. And I don't know what I'd have done if I had stage 1, but some people are quite nervous about it. And focal ablation would be a great way of knocking out small amounts of stage 1 tumours for men who are concerned about it. And there are other procedures coming on stream as well. Theranostics and artificial intelligence I raise here. Now, Theranostics is for stage 4 patients, or high stage 3 and falling into stage 4. And it's going to revolutionise how stage 4 is handled. It's only 5 years old at this moment, and Australia's been using it for 5 years, as has Germany and the Netherlands. It's just about to come to the United Kingdom, but it's not available worldwide at this stage. It depends on a molecule called PSMA, which when injected into the bloodstream loves to attach itself to prostate cancer cells. And so if you label that molecule with a radioactive nuclide, lutetium-177 being the classic one, and you inject it into the bloodstream, you've got a targeted way of handling the cancer. And that's absolutely brilliant. And this is going, and it's far more targeted than chemotherapy. So this is going to revolutionize how we look at stage 4. It may be used instead of chemotherapy, or it may be used in conjunction with chemotherapy. But also because it detects stage 4 earlier than we have been detecting it up until now, it's probably very good for getting rid of early stage 4. Artificial intelligence. Now, I mentioned the biopsy process that you would have if you couldn't have an mpMRI scan, but you will also have a biopsy if, like me, you're seriously ill, and the mpMRI has highlighted that because it's of interest to know if you've got how aggressive your tumour is. The biopsy is basically a sampling, and it's done, they take 12 samples randomly from your prostate gland. That's if it's a normal old-style biopsy, but with the MRI scan, they take 12 samples from your prostate gland, some places fewer, and it's no longer random. They'll fire the needle where they think the cancer is from the MRI scan. So they know they're going to get some samples to look at in the lab under a microscope to see if these are what the predominant cells are. Are they cancer cells or are they normal cells? Because if the predominant cells are cancer cells, you've got an aggressive cancer. If they're normal cells, you've got a modest cancer. So I've been through this. This is the one irksome procedure I went through, but you go through it okay. It's a slightly dangerous procedure in that you could finish up in intensive care if things have been very unlucky for you. And my feeling is that this procedure, it would be lovely to replace it with something else. And that something else is artificial intelligence. There are now several labs in the world who are very close to using mathematics and artificial intelligence to tease out the Gleason score from the mpMRI images. And if that can be done, that is brilliant, because then you could go through the whole process of treatment for your cancer, provided you pick EBRT, virtually with no invasive procedure whatsoever on your body. It's brilliant, if we can get this route going. So I'm looking forward to artificial intelligence coming on stream. So let's have a little bit of a recap here. Stages 1 and stage 2, it's always inside your prostate gland, and that's called early prostate cancer. Here, it's got out into the localized tissues. That's locally advanced prostate cancer, serious prostate cancer. And here, it's a field throughout your whole body or parts of your whole body. And it's called high-risk cancer. And again, we can get cures right up to this point, and we get remissions after this point, but they can be for quite a number of years. You're not looking at death if somebody says to you, you've got prostate cancer, unless you're right up here. And let me just show you where Theranostics fits in here. This green band here, there's a dead zone between knowing you're in stage 3 and knowing you're in stage 4. And with today's technology, so to speak, without Theranostics, where it depends on CT scans and MRI scans to detect when you've got from stage 3 to stage 4, they're no good in this green zone. You can't tell. You've got to wait until the metastases are big enough to be seen on a CT scan or an MRI scan. And that big enough is about 1 centimetre long, 10 millimetres, half an inch. Whereas with Theranostics, you can see how tightly we're getting down to this boundary now. You can actually detect that you're in stage 3 right up to this point, and you know you're in stage 4 here, long before you do at the moment. And what this means is you can attack stage 4 when it hasn't really got a grip. And that's why stage 4 is improving all the time. We're getting better and better and better at handling it because we're finding it earlier and we're able to hit it earlier. So that's something to watch out for. Theranostics is attacking this area here, which is fuzzy at the moment, but going to be a lot sharper. Let's have a look at some statistics now. I promised you them early on. Statistics generally are published saying what percentage of people are alive after 1 year after diagnosis, 5 years after diagnosis, and 10 years. And I've looked at the difference between breast cancer and prostate cancer. And I got this from Cancer Research UK website. They have a lot of statistics. And if you look at Britain, these statistics are about 3 or 4 years old. They don't catch up very often. Breast cancer, there's about 55,000 women, a few men, coming into it each year with diagnosis. Prostate cancer, 47,000 men. Oh, incidentally, what I should say is that breast cancer, we all know, has had acres of money pumped into it for research. It's advertised heavily. People do all sorts of things to get money into breast cancer, and they have a national screening test. But prostate cancer, you hardly ever hear of research on prostate cancer, although I've just told you about mpMRI and Theranostics. These things tend to happen in the background, and they just come out of the woodwork suddenly. And we don't have a national screening test. So we're on the underside of this. Anyway, about the 55, but the number of deaths is similar. It's about 11,500 actually, but a bit shy of 12,000, both of them. But of course that's relatively more men dying because there's only 47,000 coming in, as 55,000 here. But if we look at the survival rates, they're quite interesting. 96% of women, and the few men that are in this area, are still alive after 1 year of diagnosis, and only 94% of men for prostate cancer. Now, interestingly, that 6% fall off there, they're the men who didn't get tested until they were right at the top of stage 4. Now, you have to remember that. No stage 1 man is going to just drop dead of cancer. It just doesn't happen. Right up to stage 3 even. Doesn't happen. Unless there's some other reason for it. So we're talking here about men who didn't get tested, and therefore they were in a very bad way before they found out. And so that's why it's important for you to go and get tested. You don't want to be one of these 6%. After 5 years, well, the breast cancer patients are still a bit ahead of us. But if we go to 10 years, breast cancer survival drops to 78, and it's still 84 for men with prostate cancer. Now think about it. We don't have all the money pumped into us. We don't have all the advertising. This is just natural men coming in getting checked, it's going to get better. And if you look at these figures here, the real thing about prostate cancer is, if you weren't high in stage 4, you're just going to keep going. The number of people alive at 10 years is approximately the same as the number of you alive at 5. Once you get past 5, you just keep going. My cousin's up to 18. So prostate cancer survivability is still on the way up. And if we can get men in before they get to high stage 4, all these numbers are going to be in the 90s. And remember, these numbers are about 3 or 4 years out of date now. So the 10-year survival goes back 13 years. And the treatments have been improved out of sight in those 13 years. So these figures are definitely going to go up, no question. So take action. Lockdown has removed a lot of the time of our thoughts of being tested for cancer. We step back, we let the NHS get on with the important things. And prostate cancer is a very slow-growing cancer, by the way. I probably had my prostate cancer for 15 years before I discovered I was in stage 3. So 3 to 6 months probably won't have a big effect on any man with prostate cancer, unless he was already in stage 4 when he could start to get to the bad points. But the time is now extending. We know that we're going to be locked down for another month. This is early November that I'm saying these words. And that's even more time lost going and getting tested. And it's going to get out of control if you're not careful. So what I would say to you is, please take that first step. Make an appointment for a PSA blood test. If you've got prostate cancer, I would suspect that, like me, you will never regret it. My life's been changed. I love life more now than I did before I had my prostate cancer, because I now know that something's going to get me at some point in time, so I might as well enjoy what I've got left. And it's been extended, because I know and I've dealt with it. So, thank you for listening, if you've got this far, and I hope that you have a journey, if you have got prostate cancer, that is as good as the one I've had so far. And I do have a couple of websites associated with this, and you'll be able to get to this one from my channel page. And it's worth thumbing through this information to find out the sorts of things that you may want to do to deal with your prostate cancer if you're proven to have it. And please, once again, get yourself tested. It may be the best thing you've ever done. This is not a cancer to be frightened of, unless you let it get right to high stage 4. Thank you.